Good afternoon, everyone. My name is Sarah Dugan. I'm a psychiatric pharmacist and faculty here at NEOMED. I'm doing today's didactic, and it's going to be focused on an article that's entitled Cannabis Use in the United States and Its Impact on Gastrointestinal Health. So from an objective standpoint, we're going to discuss briefly the rationale behind why there was even interest in looking at cannabis use and gastrointestinal health. Where did that come from? We'll outline we're going to identify the actions of cannabinoids in the gastrointestinal tract and then outline the impact. So we're really going to look at what is it that we think the active compounds from cannabis do within the GI tract, and then what is it that we're seeing. And it's not going to be nearly as clear cut as I thought it was going to be when I saw the title of the article, actually. So let's start from the beginning. So why did they even want to look at this? Well, over the course of the last few decades, there's been enhanced availability of different cannabis products. There has been a tremendous shift in the legal status of cannabis products. There has been a relatively steady increase in social acceptability of the use of cannabis. And as of this spring, it has been legalized for adult use in 24 different states. The amount, the potency, and what is available does vary from state to state. And it also has been approved for medicinal use in state legislature, so not federally. Federally, it still remains a Schedule I controlled substance, so an illicit compound, but it is available medicinally in 39 different states. So the legalization and adult use are all of the green states. The yellow states are ones that just have that medical program. The orange states are ones that will allow CBD in very low concentrations of THC. So we're really seeing this roll out essentially across the country. So it shouldn't be a surprise that the overall prevalence of use has continued to steadily increase. There's a national survey done by the federal government, the National Survey of Drug Use and Health, and it follows trends looking at a number of different compounds. They've included cannabis as one of them. So for individuals who are 12 years of age or older, the use of cannabis at least once over the course of the last year was about 19% in the 2021 data. So almost 1 in 5 of the respondents had used cannabis at least once over the past year. And this was a pretty significant increase from the 11% that was seen in 2002. When they looked at daily consumption, there also was an increase with 27% of respondents that were 12 years of age or older stating that they use cannabis daily compared to 18%. So now these are percentages of those who had used cannabis, not of the total number, because obviously if they didn't use, then they wouldn't be daily users. As we look at who, so yes, the use is going up. It's going up pretty significantly. Both general use and consistent use, we see that there is some variability based on age demographics. So 12 to 17 years old has kind of been a little bit consistent. You see a little bit of an ebb and flow. There's been a pretty significant increase for those that are 18 to 25, 26 to 34, 35 to 49, and in the older population, so those that were 50 years of age or older. Now, they found some additional differences in the individuals who were using substances on a regular basis. They actually found that individuals who had medical conditions were much more likely in the adult population, so those that were at least 18 years of age or older, to be using cannabis than kind of their age-matched peers that did not have medical conditions. So it really is being looked at as something that can be incorporated into treatment. This is something that we really want to keep in mind. So individuals that have conditions of pretty much all ages are using this, and we've seen a pretty steady increase in potency. So in 1995, the average active ingredient, the delta-9 tetrahydrocannabinol, percentage in cannabis plants was about 4%. In 2019, it was 14%, and in 2022, it is 16%. Now, I do just want to word of caution. So these are percentages based on plant material. So if individuals are using dried plant material to smoke, then that's the percentage that they're getting. But we've had tremendous formulation diversification. So those who are using any type of oil, extract, shatter, so they're like little uh, so there are little pods that you can get that they can vaporize, different wax components. There are sleeves, or they're sheets, not sleeves. They come in a little sleeve. They're sheets that can be put on a vaporization device that will allow for inhalation of cannabis. And those percentages of THC can go up significantly higher. Those percentages will depend and vary state to state, but with the higher THC concentrations, the other considerations that need to be taken into account is how deep an individual is able to inhale, how long they're able to hold their breath. So we're really looking at a totally different cannabis product than what it was even just a couple decades ago. So recognizing that there are all of these differences and we don't have a ton of data, it's growing, the efficacy and safety data, but there were some concerns that were raised about, well, what exactly is it that this is doing? If folks are using it, is it helpful? Is it something that could be harmful? How should we be able to advise these patients moving forward? So that's really where this started to come from. And as they were looking at the all of the cannabinoid products, it was recognized that there are differences. So endocannabinoids, we have natural cannabinoid compounds. And this, I think, is really where a number of individuals have aligned themselves, saying, if I'm going to use a cannabis product, it's fine because it's natural. Yes, we have cannabinoids in our brains right now. We have two compounds, so N-arachidonyl ethanolamide, easy for me to say, and 2-arachidonyl glycerol. Those are not the cannabinoids that we see in plant material. So when we look at the cannabis plants, the phytocannabinoids are the ones that most individuals are getting exposed to. So there are more than 400 different compounds in the cannabis plant. The two that we focus on are delta-9 tetrahydrocannabinol and cannabidiol, so THC and CBD. Those are not the only ones. They're not the only ones that are psychoactive. Those are not the only ones that are physiologically active. Those are the ones that we're going to focus on today. But something to be said about the fact that if we're using this, we're likely using compounds that we're really not comfortable or familiar with, where we need a lot more information. Now, some of those products and compounds, so THC in particular, has been made synthetically. So that was made into dronabinol. So Marinol, which is an FDA-approved product that can be used for, that was approved for chemotherapy-induced nausea and vomiting. It also was used for loss of appetite in patients who have acquired immune deficiency syndrome. We also have a CBD compound, so that's able to be used for patients with refractory epilepsy, the Dravet syndrome. So we do have some compounds that have made it down the traditional FDA path, but that's really, the doors have kind of been blown off. There's not a huge incentive to go down the synthetic path at this point when this is so available. And there are so many compounds and it has a lot less restrictions for its use for kind of the general patient. So recognizing that we're not likely to have some of those safeguards in place, we need to take a look at what is going on and where might this have an impact. So all of those compounds that can be found in cannabis work on the cannabinoid receptors. So we have two main cannabinoid receptors, so CB1 and CB2. It originally was CB1 is in the brain, CB2 is more peripheral and in the immune system. Well, that's not totally true. As you can see from the light blue and the dark blue dots, we have CB1 and CB2 receptors pretty much all over the place. It does follow the brain, the spinal cord, and it is concentrated kind of in the belly abdominal area. So not a surprise that gastroenterologists are really interested in this. It's also been discovered that cannabinoids have action in a number of different areas, and these are the ones from the article that I am going to focus on. The one area that I did cut out, I more cut it out just for sake of time, is related to hyperalgesia and stress, but we'll kind of talk about that a little bit as we get farther down. So esophageal functioning. So cannabinoid 1 receptors are found in the esophagus, and they appear to play a role in the relaxation of the lower esophageal sphincter. So at the end of the tube that connects your mouth to your belly, we have almost like a rubber band. So that sphincter is what's supposed to open as you're swallowing food, and then it's supposed to close so that your stomach is able to grind up the food into a different form that your body can then absorb the nutrients from. So it's really important that we have appropriate tone in that particular area. It can result in problems including reflux, potentially vomiting. So we'll get to the vomiting a little bit later. So we see that this could potentially be problematic. There was a study that was done that looked at a investigational compound that was a cannabinoid 1 receptor antagonist. So it was blocking the actions of the cannabinoid receptor. And what they found was that there was increased postprandial, so after the subjects ate, there was increased tone in that lower esophageal sphincter compared to when they were not exposed to this compound. So it did look like actions on this particular receptor did impact how much contraction and tone was present. So what does that mean for patients? There were 2 trials that were included here. So a case control trial. So this looked at individuals who had so it was a single center retrospective case control trial, and they were looking at individuals who had used cannabis and those who had not used cannabis. They were age and sex matched, and they actually had some swallowing studies that were done, and they found that individuals who had used cannabis had impaired bolus clearance. So their ability when they chewed to be able to clear that completely down the esophagus into the belly was significantly more impaired than, so it wasn't as smooth a process as those who had not been using cannabis. There was also decreased lower esophageal sphincter relaxation. So if that little elastic band that controls the entrance to the stomach doesn't release enough, you can't get your food into your belly where it's supposed to be. And they did see that almost a third of individuals who are using cannabis didn't have as much relaxation as those who were not using cannabis. So again, not that any of them had a particular medical condition, but they had been evaluated with those swallowing studies, and they did notice a difference in those who did have cannabis exposure. Now, were they using cannabis because they were having issues, or is this a result of the cannabis use? And that's really where some of those questions start to pop up. So there was one clinical trial. So it was randomized, double-blind, placebo-controlled. They had individuals take oral THC. So they essentially were taking edibles. And what they found was that there was a decrease in spontaneous swallowing. So individuals weren't as likely to continue to swallow spontaneously, and there was decreased postprandial lower esophageal tone. So they did see that there was less less contraction of that lower esophageal sphincter. So these were all in healthy adults. So again, they did not have anything, any particular conditions. So it is possible if individuals are having difficulty, if they do have reflux, if they have potentially issues with their lower esophageal sphincter, that this could potentially be one of the interventions that they might be able to use. On the flip side, if they have things like reflux, it is possible if they're using this, that may make that condition worse. So it will be something that we're going to need to continue to monitor. So yes, there is an impact here. What is that going to mean? We're going to have to trend that out a little bit, but it may have an impact if folks are complaining about symptoms. So let's move down the GI tract. So now we're going to look at the belly. So gastric emptying. So how quickly is the food getting from your belly into your small intestines where we're able to absorb the things that we need? So again, the CB1 receptors have been associated with changes in gastric emptying, specifically that it may delay gastric emptying, so make it a little bit longer, a little bit slower. So in some cases, that might be a good thing for some individuals who may have an expedited transit time. That may be problematic for them, but for other folks where they're not moving things along, this may be problematic. So there was a retrospective study done, so a study that was looking at patients who had a diagnosis of gastroparesis. So essentially, they had really slow movement of food throughout their GI tract. So it was just under 200 patients, and they found that individuals reporting cannabis use had a lower gastroparesis cardinal symptom index total score. So yes, they had the condition, but the severity of their condition tended to be lower than individuals who were not cannabis users. It also, I guess, not as much of a surprise when they asked individuals about the cannabis use, they were more likely to perceive that it was beneficial to them. So in determining whether or not they thought that could be helpful or harmful for their condition, they were much more likely to say that it was going to be helpful for their condition than individuals who were not using cannabis. They were more likely to consider it either not having a benefit or potentially being detrimental. So severity-wise, they weren't quite as severe, but is it because they were using cannabis, or was that just an arbitrary finding? That's something we'll need to investigate further. So there was a cohort study that was done. So this was also done in patients who had gastroparesis. They looked at all of the patients who had gastroparesis. Those that had reported use of cannabis tended to be younger. So they were just almost 37 compared to almost 52. And they were more likely to be male. So where almost 53% of individuals with gastroparesis who were cannabis users were male. Those who had gastroparesis that were not cannabis users, only a third of them were male. So we did see a pretty significant difference. So did the use of cannabis make symptoms come on sooner for this cohort? Maybe, but when they followed the patients out, they found that cannabis use was associated with a shorter length of stay in the hospital and lower mortality rates. So patients didn't have to be hospitalized as long, and they were less likely to pass away. So again, severity-wise, maybe it was a little less than what we see in those individuals who were not using cannabis. So intriguing findings that might it be a risk factor or might it be actually beneficial for the condition? So the clinical trial that I included here was a randomized double-blind trial. Other page of my notes. These patients had functional dyspepsia. So they were randomized and they were given either a cannabidiol or they were given placebo. So the other two, it was just cannabis report. If they reported use, that's the category they were put in. For this one, they were actually split into the group and administered the cannabidiol for a month. They followed them out. They tracked their symptoms. They did a number of studies both before they started the treatment and at the end of the 4-week time frame. They did not see any difference in symptoms of dyspepsia or in gastric emptying times. There were a couple adverse effects, including sedation, that were a little bit higher with the CBD group, but it's unlikely they knew which condition they were on. Which is intriguing because one of the potential confounders is if I'm using cannabis and I think it's helpful, that's what I'm going to report. Whereas in this trial, if I'm not sure what I'm on, then I may be less likely to say my symptoms are better because I'm not really sure if they're better or they actually haven't improved. So looks like there is action here, but nothing clearly definitive for most of these most of the patients with these different disorders. So we'll move a little bit further down the GI tract. So there are recognized actions of the cannabinoids on the colon's motility, secretion, and inflammation. So this is going to have an impact those gastroparesis patients, patients who have inflammatory bowel disease, those that suffer from chronic constipation or diarrhea. All of those could potentially have actions by the cannabinoids. We see both receptors get involved here. So the CB1 receptor, activation of this receptor has been associated with decreased secretion and decreased contractility. So potentially some utilization in patients who have chronic diarrhea as part of their inflammatory bowel condition. And then the CB2 receptors, activation of these receptors result in downregulation of inflammatory cytokines. So it's possible that this can reduce the overall inflammatory mediators and try to decrease the amount of inflammation that's being caused by this condition, thus hopefully reducing symptoms. So there were a few more studies looking at this. Several of the states across most of the states that do allow medicinal use of cannabis do have different inflammatory bowel conditions that are included as qualifying medical indications. So this was a cohort study, 31,000 patients. They were able to look at inpatients in a couple large health system databases. So adult patients who had inflammatory bowel disease that needed to be admitted to the hospital. So they were looking at cannabis use. So again, cannabis use was associated with more frequently with individuals who are African American, those that had a lower socioeconomic status. They were more likely to be male. And they, again, were presenting hospitalized at a much younger age than individuals with IBS that had not been using cannabis. So again, is that a risk factor for it? Maybe, but the use of cannabis was also attributed to relief of symptoms. So in individuals who reported severe abdominal pain, those that had a history of abdominal surgery, the severity of their symptoms was lower if they were using cannabis than those who were not. So is it helpful? Is it harmful? Again, it's kind of a muddy picture, but it definitely appears to be playing a role. There was another national inpatient study done, again, looking at some national health systems databases, adult patients who had inflammatory bowel disease. In this case, the individuals who were hospitalized for IBS were less likely to require an endoscopic procedure. So they didn't need any additional imaging or any type of procedure as a result of that. They had a shorter length of stay in the hospital and they had a lower median cost. So they were less expensive to the health system if they had been using cannabis. So this one really focused less on were they more likely to be admitted or did that seem to be a risk factor for admission, and more on the treatment side of things, demonstrating that overall their severity, severe enough to be hospitalized, but appeared to be a little bit lower. And is it because folks with less severe conditions used the cannabis, or did the cannabis result in the IBS being less severe is still up for discussion. The last trial here is a prospective trial. So they enrolled patients who had irritable bowel syndrome, and they had them administer inhaled cannabis for 3 months. So this was vaporized. This was not smoked, dried plant material. And they followed them over that period of time. They monitor a number of different parameters. At the end of the 3 months, the individuals who had been using the inhaled cannabis on a regular basis had improved quality of life scores. They had a decrease in the disease severity index. So the severity of their condition was less than what it had been 3 months prior. And they did have weight gain. So many of the patients who have more significant IBS symptoms may not have much of an appetite and may have some significant weight loss. So they did see a reversal of that. Now, from a objective standpoint, in terms of inflammatory mediators or other objective outcomes, this was much more on the subjective side, so more on the patient report than collecting that specific lab data, imaging data, those type of things. So from the functioning standpoint, appears to play a role in the esophagus. We see an impact on gastric emptying. And then on the colonic function, yes, it appears that it is being fairly widely used by a number of individuals who do have different conditions. There were a couple other colonic function studies looking at patients who had ulcerative colitis or those who had Crohn's disease. Those did not show consistent results. So is it only helpful with some of them? Do we just have more data in the IBS patient population? It's really unclear at this point. Does it play a role? Yes, it appears to have some type of an impact, whether it's a help or a harm. I think it depends on what we're looking at. And we only have part of the picture, which makes it really difficult to say, yes, we should be using this robustly, or this might be a risk for those patients. So trying to transition a little bit from the function of those two, what about some of the other considerations that we see with the GI tract? So the microbiome. So we have over 100 trillion microorganisms. There are thousands of different bacteria. And there is a very clear relationship that has been articulated more recently between the microbiome, the gut, as well as the brain. So this has a tremendous impact on different inflammatory mediators and signals, on different neurotransmitters. There are a number of animal models that have demonstrated just by changing a patient's stress level, you can impact what their microbiome is. By changing the animal's diet and potentially changing what their microbiome looks like, you can actually impact gut symptoms as well as mood and behavior symptoms. So they've been able to show that by altering any one of these three categories, we actually see changes in all of the other categories. Interestingly, they've also been able to demonstrate that the gut microbiome does impact endocannabinoid activity. So depending on the changes in the microbiome, they've been able to identify a number of different changes within the endocannabinoids, including receptor density, as well as overall downstream activity. Now, some of the actions as a result of the endocannabinoids are gut motility, secretion, permeability, and nutrition absorption. So it is very possible that the use of cannabis may impact the overall microbiome. They did not necessarily take it the next step to look at, okay, so do we have changes in mood or anxiety or sleep levels that then result in changes in the microbiome or other gut symptoms? That's the direction that a number of different investigators want to go in. It's a little more complicated to set up a clinical trial that way. So at this point, a number of the recommendations are really to look at encouraging the use of pre and probiotics. So lactobacillus being the primary one. It's been reported in animal studies that the use of lactobacillus, which is one of the main probiotics that are marketed, has demonstrated an increase in endocannabinoid concentrations. So those those two compounds, the AEA and the 2AG that we make, those have gone up with the administration of lactobacillus, and the concentrations of the cannabinoid receptors have gone up, at least in those animal models. So promotion of endocannabinoid activity may potentially be impacted by the use of probiotics. So that was kind of interesting on the nutritional health side of things. The one I thought was going to get a little bit more attention in the article really was nausea and vomiting. So we've known for an extended period of time that cannabinoids have a role in nausea and vomiting. The cannabinoid receptors are in a number of different locations in the brain that are directly related to nausea and vomiting. Activation of the CB1 receptors has been associated pretty clearly with decrease in emesis, both for individuals who have cyclic vomiting as well as those who may have vomiting induced by chemotherapeutic substances. There was a prospective analysis done in patients who had cyclic vomiting syndrome. So these are individuals who kind of go through a cycle where they have these acute attacks where they're vomiting on a pretty repetitive basis. So they'll have significant nausea, they'll have significant abdominal pain, and as you can imagine, this can be incredibly detrimental to the patient and their ability to carry out some of their other responsibilities. So they just wanted to look at the patients who had cyclic vomiting syndrome. What do the levels of those endogenous cannabinoids look like? And they found that compared to their peers that did not have cyclic vomiting syndrome, they had lower concentrations of 2-AG and the AEA. So the endogenous cannabinoid concentrations were significantly lower. So the suggestion is maybe it's a deficiency in this system that actually may result in cyclic vomiting syndrome. Can that be proven? No. Is it potentially a result of all of that vomiting that their concentrations are lower? Maybe, but it was an interesting finding. There was a case control trial done in over 260 patients. So they took patients who had cyclic vomiting syndrome, and they wanted to see genetically, can we find any differences? So if we think there's a deficiency, are we able to genetically prove that we can identify who these patients may be? There was a polymorphism in the CB1 gene that is associated with risk of the disorder. So compared to the general population, more individuals had this particular gene sequence in the CB1 receptor realm. And they found one particular SNP. So in the genetic code, if you make one base pair change in some of these, it's called a single nucleotide polymorphism. They actually found a couple SNPs that predicted whether or not patients would respond to treatment. So it looked like if there was a particular sequence for the cannabinoid 1 receptor, you're more likely to have cyclic vomiting syndrome. And then based on your sequence, if you have these particular sequences, you're much more likely to respond to treatment. Now, that's interesting overall. So it appears that the cannabinoids can be really beneficial for the treatment of vomiting. But it's been recognized for over a decade now that there is a subset of individuals who have something called cannabinoid hyperemesis syndrome. So this was a condition that was originally identified after a case series of 9 patients of individuals who had been chronic users of cannabis came in with intractable vomiting. So they happened to be in the same region, and there was a physician who kind of identified a pattern and was able to report on it. So this appears very similar to the cyclical vomiting syndrome. So patients may become nauseous, they develop some abdominal pain. The nausea and abdominal pain persist or may actually get worse. And then the patient may have repetitive vomiting, so where they're really just not able to keep anything down. This will result in decreased food intake. It can result in weight loss. And many of the patients were presenting because this had gone on for a long enough period of time that they were dehydrated, pretty severely dehydrated, and required medical intervention. Now, interestingly, one of the other aspects of this was that many of the individuals would seek out hot showers. So when they had these episodes, they would have a really hot bath or take a hot shower, and they would do this repetitively to try to relieve some of those symptoms. Now, originally, that was one of the interventions, and it was thought to potentially break up the process. That and the recommendation was to essentially discontinue the use of cannabis, and then they would see symptom resolution. Well, they've been investigating this for a while now, and they actually have found that folks who have cyclical vomiting syndrome, so vomiting that's not necessarily associated with chronic cannabis use, there's about 50% of them that also seek out that hot water therapy, so that are taking some of those hot showers. So now it's not really clear if that's actually a treatment intervention or if that may be part of the cycle itself. The other thing that I was a little bit surprised by is that when they've followed some of these patients, so most of the information is on case reports. So it's case reports. We don't have a lot of follow-up data. It was estimated that less than a third of patients who have this present for follow-up with their medical providers. They get resolution of their symptoms. They feel much better. So they're out of the urgent care, they're out of the emergency department, and they're not trying to follow up on this particular condition. Of that small percentage that were able to be followed up on, they looked at the number of patients who had been able to abstain. So about 88% had abstained for over 1 month. And of the 88% who had abstained from cannabis, there was only one patient that had complete resolution of their vomiting symptoms. So even with the abstention from cannabis, there were still some patients who ended up going back into this cycle, having pretty significant nausea, abdominal pain, and vomiting. So the questions are starting to be raised about, is this from the cannabis? Does it uncover a patient population that may be at higher risk? So this really is an area that's starting to develop. That's why I gave my little chicken and the egg here. I think when we first started presenting on it, we were like, okay, this is a risk factor, but maybe we see this in patients who are chronic cannabis users, but that may not necessarily always be the driving force. That may be something that just uncovers another condition. So definitely involved in the nausea and vomiting process. Help or hindrance, I think it still is out to be determined, which was kind of across the board for all of these conditions. So cannabinoid activity definitely present throughout the GI tract. We see potential impact throughout the GI system. There's a higher prevalence of cannabis use in certain subsets of patients, including those with inflammatory bowel syndrome. So yes, it's more prevalent in them, but are they using it for the symptoms? Because we're also seeing lower severity of symptoms and requirements for intervention in those patients. So does play a role? Is it a risk or a treatment? We're not really sure yet. And then similar for nausea and vomiting, it's been established as a treatment intervention to reduce nausea and vomiting in chemotherapy patients, as well as to improve appetite in patients who had lost a significant amount of weight, including those who are HIV positive. But its role in that potential exacerbation in the hyperemesis syndrome is not quite as clear as what I think we expected when we first encountered the hyperemesis syndrome. So more to be determined. So if you have patients who have gastrointestinal conditions and they are cannabis users, I think it's going to be really important for them to be tracking what their symptoms are. So based on what they're using, based on the frequency and the potency of what they're using, they'll then need to track their own symptoms to see if it has been beneficial or if it might be detrimental. So that is what I have for our didactic today.